Okay, good morning, everybody. Thanks for the kind presentation, and it's a great opportunity of being here. It's a pleasure to present this work to this audience about a new 2D echocardiographic approach to evaluate the membrane and valve movement of the Berlin-Attack score valve chamber in pediatrics. So we know that serial echocardiography of VAD patients is necessary for patient selection and monitoring, and also to evaluate the VAD itself to detect VAD malfunctioning and to study the interaction between the VAD and the native ventricle. More efforts are focused on the development of innovative techniques to evaluate the functioning of continuous flow VAD, such as in the work of Dimitrov et al., while there is a paucity of data regarding the evaluation of pulsatile flow VADs, such the Berlin-Art. So assuming that the pump is a system composed by two cannulas, an inflow and an outflow cannulas, in which we can find a three-leaflet valve, an inflow valve and an outflow valve, which are similar to the native civiluminar valves, and a chamber in which we can find a moving membrane, we conducted a serial and systematic echocardiographic study of these Berlin-Art components. So to this aim, we conducted a prospective clinical study enrolling all pediatric patients undergoing Berlin-Art at our institution from 2014 to 2017, and all patients were evaluated weekly by echocardiography in order to study the Berlin-Art valves and membrane. In particular, to study the functioning of the Berlin-Art valves, we directly placed the probe, the echocardiographic probe, on the inflow and on the outflow cannulas of the devices. While to evaluate the membrane movement, we placed the echocardiographic probe directly on the chamber. So we evaluated a total of 40 Berlin-Art score VAD on 16 patients, and as you can see, we have different sizes of Berlin-Art. 7 VAD were placed as RVAD and 33 as LVAD, and we observed no regurgitation in 19 inflow and 50 outflow cannulas, mild regurgitation in 14 inflow and 21 outflow cannulas, moderate regurgitation in 5 inflow and 3 outflow cannulas, and severe regurgitation in 3 inflow cannulas. But what does it mean, this regurgitation? As you can see here from the video, maybe, okay. Yes. Here you have the valve leaflet opening to the right. So to the right you can see the anterograde flow, while to the left you can see the retrograde flow. In this slide you can see that there's no retrograde flow, so it means that it is a normal functioning valve. While in this case you can see that the valve is going to opening to the right. Sorry, it was the opposite in the previous slide. It is going to open to your right. So on the right you can see you can see the anterograde flow, to the left the retrograde flow, which is not present in this. Okay, the second example, you see that the valve leaflet is going to open this direction. So you have in this direction the anterograde flow, and you have also some backflow in this case that was defined as mild regurgitation. And here you can see an example of moderate regurgitation. So you can see that the valve leaflet are going to open in this direction. So in this direction you have the anterograde flow, and in the opposite direction you have some retrograde flow, which is higher than in the previous condition. And here you can see also the M mode. In the M mode color, the white box represented by the white line means that we have the valve is open, while when we don't have the white line, it means that the valve is closed. When you don't have any regurgitation, you have that all the flow is concentrated inside the white box, while when the valve is closed, we don't have any flow. While in the case of regurgitation, we have the majority of the flow, of course, during the opening of the valve, but we also have some regurgitation and turbulent flow when the valve is closed. So, but why do we have this valve regurgitation? Is it a mechanical problem of the device? Is it an hemodynamic problem? To answer to these questions, we had to evaluate carefully the 3 cases in which we had the severe regurgitation. This is the first case. We defined severe regurgitation as the condition in which we have the backflow into the heart chamber. So in this first case, we have recycling blood into the left ventricle because of the regurgitation of an inflow cannula of an LVAD. And we changed the device, and as soon as we changed the device, we saw that we have no regurgitation. We sent the device to the manufacturer, and in this case, they confirmed a mechanical alteration of the valve. So in this first case, it was a problem of the device itself. In this second case, we have the backflow into the right atrium because of the regurgitation, as you can see from the transesophageal echocardiography. In this second case, again, we substituted the device starting from the experience of the first case, but we didn't solve the problem. So we performed a transesophageal echocardiography on patients, and we saw that the problem was also due to the fact that there's some clots around the right atrium. So as soon as we opened the chest of the baby, removed the clots, we saw that we have a reduction of the regurgitation. So we can say that we have a sort of mixed etiology. And in the third case, the last case, we have regurgitant into the left ventricle because of regurgitation of an inflow valve, of an inflow cannula. And, sorry. Okay. And in this case, we performed the transesophageal echocardiography, and we saw that the problem was due to the fact that in these patients we have a phenomenon of suction. And so, as you can see from this video, we have a very small flow here, but as soon as we solved the suction, we have normal flow into the inflow cannula, and with this method we can reduce the regurgitation of the valve. So also in this case, we have a mixed etiology. Okay, here are some results about the membrane. Here you can see the M mode of a normal moving membrane, the video of a normal moving membrane, while this is the video and the M mode of an abnormal moving membrane, not completely filling, not completely emptying. And finally, we had the chance to evaluate the beat phenomenon. The beat phenomenon is due to the fact that the VAD rate is different from the heart rate, and also that the VAD and heart works are not synchronized. So this difference causes the beat phenomenon when the aortic valve opens and the Berlin heart is ejecting, and the disturbance is transmitted to the patient's cardiocirculatory system and to the Berlin heart. This is a typical example. As you can see from this M mode color, we have the opening of the valve, the closure of the valve, and then a very short opening of the valve, which is not something that we would like to have, but it is due to the beat phenomenon, so to the interaction between the VAD and the heart. This is the beat phenomenon in the case of atrial fibrillation. This is a funny picture. And here you can see the beat phenomenon in the case of cardiac tamponade, cannula tamponade. So this is the fluttering of the valve of the Berlin heart. And as soon as we solved the problem of the cannula tamponade, we obtain again a normal pattern. But as you can see, we have, yes, a normal M-mode pattern, but we have also some regurgitation, also even because we have the mixed etiology of the problem. So in conclusion, echocardiography in Berlin heart patients could be useful to evaluate VAD functioning and VAD-heart interaction. The echo permits to assess the beat phenomenon and the function of the Berlin heart valves and membrane. This method could be an additional tool to make diagnosis on our patients. Some curiosity. We experienced one case of detachment of membrane layers, and so we made the diagnosis using the CT scan, but it would be of interest to understand if this echocardiographic method could be useful to evaluate this very strange case. But unfortunately, during that period, we didn't use this method yet. And finally, further studies could be necessary to refine the method and to collect additional data to deeply understand the Berlin heart functioning and the interaction between the heart and the VAD, as well as the possibility to detect thrombus formation. Thank you for your attention.